Infection Prevention and Control. I'm Wayne Sharp, a health media specialist with the Internews Rooted in Trust project. And Internews is one member of the group hosting this dialogue, the Media Task Force of the Eastern and Southern Africa Interagency Working Group for Risk Communication and Community Engagement. My co-moderator today is Tole Nyata, an Internews pandemic media mentor based in Zambia. Since the outbreak of Ebola on 20 September, a total of 141 cases and 55 deaths have been confirmed by the Uganda Ministry of Health, according to data released on the 21st of November. In addition, there are 22 probable Ebola cases, all resulting in death, and there have been 19 cases resulting in 7 deaths among healthcare workers. In today's dialogue, we're going to focus on Ebola infection prevention and control and the many issues surrounding that. Our guests will address concerns about the treatment of Ebola patients and the misinformation surrounding these procedures. So we're joined by the WHO lead in Ebola infection prevention and control to take us through procedures. And we'll also be joined by a Ugandan journalist to give us her perspective on the challenges journalists are finding in getting answers to their questions regarding this outbreak. I just want to quickly remind you that if you have a question for any of our speakers today, please type them in the Zoom chat box, and my co-moderator Tole will ask them of our speakers during this hour. Before we get to our keynote speakers, we like to have this session where we look at the community feedback we've been hearing on social media about Ebola. So joining us now is Sylvia Somariva of UNICEF. She'll share the latest community conversations, misinformation, and rumors on social media that UNICEF and other groups are tracking in the ESAR region regarding the Ebola outbreak. Sylvia, welcome back to the Media Dialog.
Thanks, Wayne. Hi, everyone. Nice to be back. Let me screen share real quick. I just have a few slides to share. You should be able to see my screen, hopefully in slideshow mode. Let me know if you have any issues with that. So as Wayne mentioned, we are conducting social media monitoring, digital news monitoring around the Ebola outbreak at regional level. So we are looking at Uganda, of course, and also the preparedness countries. So most of the content we are tracking on a weekly basis is typically from users or accounts that are geolocated in Uganda, and a proportion, about 1/5 generally, is from users in Kenya, and a smaller percentage in Tanzania and other countries nearby. So compared to last week, the engagement level around Ebola on digital has been 20% higher, though we have seen a steady decline over the course of the month. So we see some fluctuations on a weekly basis now, but typically the engagement level and conversations are much lower compared to a month ago this time. Most of the content we are tracking is in English, and then about 15 to 20% typically is in Swahili. So of course, this is limited to users and outlets that have a digital presence. So in terms of key trends over the past week, you can see that mortality and treatment have been 2 main subtopical conversations that have been mentioned online. Particularly the news that no new deaths due to Ebola have been reported generated high interest, alongside statements from the Ministry of Health. There was also a video showing staff from the Ebola Treatment Unit in Mubende celebrating the discharge of the last patients that made the rounds on social media and generated quite high engagement. We also continue to track concerns about restrictions, particularly lockdowns in the affected areas, with many users calling for these measures to be lifted. In terms of some specific search queries that we tracked on Google and YouTube, you can see that people have been searching for updates on the number of cases, how is Ebola transmitted, as well as the video from the speech of President Museveni a few days ago. On social media, some of the questions that we tracked included, should I be worried about Ebola during the festive season? This was tracked in Uganda. since when did we move from Ebola back to COVID? This was in relation to President Museveni's statements around the COVID vaccine certificate requirements that are coming back for public spaces and public gatherings. And also, why is there still a lockdown in Mubende and Kasanda when we are hearing that there are no new cases, and we are hearing statements that the outbreak is towards the end? So those are some of the questions that people are asking on social media. In terms of a few narratives to watch, this is not dramatically different from what we have seen in other weeks. We see some conspiracy claims that the outbreak is not concerning and just sort of a way to drive profits. These we have been tracking since the beginning of the outbreak. Some users are saying that the decline in cases is a proof that this was never a real emergency, but just sort of a way to drive profits or to attract funding. The announcement that I mentioned that COVID vaccine certificates will be required again in public spaces also fueled this sense that COVID and Ebola are interchangeable public health emergencies that are being used to implement control and restriction measures. We have also seen some questions regarding school closures, particularly why have schools being closed so promptly if the outbreak is already under control. And so users asking about education and the sort of early dismissals that students received. So those have been the main trends for the past week. Over to you, Wayne.
Thanks so much, Sylvia. That's very interesting data there. I think we'll pick up some of those themes during our talk with our keynote speakers today. Okay, for our first keynote speaker, Dr. Landry Kabego is a medical doctor and specialist in medical virology and infection prevention and control, or IPC for short. He works with the World Health Organization in Brazzaville, where he leads the infection prevention and control team under the cluster of emergency preparedness and response. He has supported Ebola responses since 2018 in DRC, Guinea, and Ivory Coast. As part of his daily work, he's guiding member states on the process of establishing or strengthening their IPC programs at national and healthcare facility levels. Dr. Kabego, welcome to the Media Dialog.
Thank you so much, Wayne. It's a pleasure to be with you today. Can you confirm that you can see my screen, please?
Still waiting to see. Not seeing you yet.
Not yet. Maybe it's coming. Let me try to reshare. Stop sharing.
Oh. Aha.
Now you can see it.
There we go. We're all set. Thank you.
Okay, thank you so much. So it's a pleasure to be with you today. I'm going to provide some basic principles of infection prevention and control in the context of Ebola virus disease outbreak. So the first slide that I would like all of us to really focus on is how infectious diseases they can transmit from one person to another. This is what we call the chain of transmission. And this chain of transmission has 6 elements. If one of the 6 elements is missing, the infectious disease is not going to be transmitted from one person to another. And the first element is what we call the infectious agents, the infectious pathogen, which are microorganisms. They can be called as well the germs. And we can have bacteria, we can have parasites, fungi, and in this case, we have a virus, which is a tiny microorganism, very small microorganism. You cannot see it by your own eyes. You just need electronic microscope to see it. And for this virus, which is Ebola in this case, the strain that we have, it's called Sudan virus, but I will be calling it just Ebola, as many people are used to that name. The infectious agents need to be somewhere where it can live and reproduce, because viruses, they can only reproduce in other in animals, in human, etc. So they use the animals or the humans system to multiply themselves. So if you put a virus on a table, it cannot multiply. So it needs a cellular mechanism of animals and humans to multiply. And we can have several types of reservoir. For example, for cholera, the reservoir, it can be water. For Ebola, the reservoir, it's human beings. But at the beginning of the pandemic, the outbreak, before it arrived to a human being, the reservoir of Ebola is wild animals like bats or monkeys. So we have our reservoir, and when the virus is inside the reservoir, to get transmitted, it needs to leave the reservoir. If it stays in the reservoir, it's not going to transmit itself. And that's what we call a portal of exit. And the human being has a reservoir for Ebola. To leave the body, it needs to leave through the respiratory system, it needs to leave through the body fluid, vomit, diarrhea, etc., etc. And when the virus leaves the body of a human being, there is what we call the mode of transmission. We need to have a mode of transmission so it can go from one person to another. And the mode of transmission in case of Ebola, we have direct transmission, direct contact. When you touch somebody with Ebola, and you touch his body fluid, and then you bring that body fluid to the portal of entry. And your portal entry as well is all the mucus, like the respiratory system, the mouth, the eyes, but as well as wounds. And when you get Ebola in your body, you can be sick or not. So the host need to be susceptible to develop the disease. If you are not susceptible, you are immunized, you are not going to develop the disease. And this is the foundation of infection prevention and control. And all the mechanisms that we are putting in place to prevent the transmission of Ebola virus from one person to another are coming from this chain. So for example, the reservoir, when you say the human being is a reservoir, so how are you going to do to make sure that the virus doesn't leave the reservoir to go to another person? You're going to isolate the reservoir. You're going to isolate the human being to make sure that he's not in contact with other people. For example, the portal of exit, if you know that when somebody is speaking, he can remove the droplets, you need to wear a mask. When the patient is wearing mask, he's not going to remove the droplets. And the mode of transmission, as I said, it can be transmitted through direct contacts, but as well as through indirect contacts. When you touch a surface that is contaminated by body fluid of an Ebola patient, you are going to get sick. So you need to clean and disinfect the surfaces. And also when you use a medical doctor, use materials that are infected from the Ebola patient to a patient who is not infected, is going to be infected, the other patient. So you need to clean, disinfect, sterilize the medical devices. When you are a medical doctor, you want to do the examination of a patient with the Ebola, as a medical doctor, you need to protect your portal of entry by, for example, keeping the distance or wearing personal protective equipment. So even if you touch body fluid, you know you have your gloves. Even if the patient release respiratory droplets, you know you are wearing your eye protectors, but as well you are wearing your mask and you are protecting yourself. And in case of Ebola, you need to be fully protected when you want to interact with an Ebola patients. And the last one is the vaccine, susceptible host. For this current strain, the Sudan strain, there is no approved vaccine. But for example, for the Zaire strain, there are approved vaccines. And when somebody is vaccinated, the probability to get the disease become low. Even though someone can get the disease, but the probability is low. And usually when a vaccinated person gets the diseases, it's not a severe disease. And lastly, let's say the infectious agent. You can kill the infectious agent using the medications, even though for the Sudan strain, there is no medication to kill the infectious agent. But for the Zaire strain, the Ebola in DRC, there is a medication, antivirals that can be used. So this is the summary of why we are using these measures to make sure that we protect people. I'm going to leave the full screen so I can interact a little bit more. This is a picture a picture of an Ebola treatment centers. So when we design a treatment center for Ebola, we need to take this into consideration, the mode of transmission of Ebola, to make sure that we don't mix health workers, suspect cases, and confirmed cases. And this is an example of how to design a treatment centers. A treatment center has two parts. The first part is what we call a low risk area. Health workers, they are here. This is their area. It's a low risk because they are not infected. And the second part is this one, the higher risk area. This is where we have the patients. And in the high risk area, we divide it into two, like this. So this part here is for suspect cases. And this other part here is for confirmed cases. And when a medical doctor that is called Henry arrives to the Ebola treatment centers, he has to use the entrance for medical doctors or for health workers. He's coming with his normal clothes, and then he arrives here. He wears a scrub and boots, and then he can go to a meeting room. There is somewhere a pharmacy. Sorry, I cannot see. It's very, very small. There is somewhere where he can eat, and when he wants to leave, he can leave from the same door. But now, if Henry enter in the low risk area, and
Excuse
then,
me, Dr. Kabego, are we supposed to see an image here?
yes,
We're not seeing that. We're not seeing that. Yeah.
Okay, sorry.
That's okay.
Now you can see it.
Ah, there we go. Okay.
Okay.
Yes. Sorry about that.
Oh, really sorry. So in summary, the low risk area is in black, and the high risk area is in red. So this high risk area is divided into two. High risk area in red divided into two, like this. This part is for suspects, and this part is for confirmed cases. So I was saying that Henry enter here, he changed his clothes here, he can go to a meeting room, he can go to the pharmacy, just wearing the scrubs and the boots. Now, if Henry wants to go to the suspect patients, he needs to wear his full PPEs, his full personal protective equipment. He enters here, he sees the patients, he examines the patients, and this is only for suspect cases. He treats them, he provides them medication, etc., etc. And then, if that day Henry is not going to go to the confirmed cases, he can go directly here, he disinfect himself, and then enter again in the low-risk area. But if Henry, when he finishes with the suspect cases, he wants to see the confirmed cases, he can take this road and enter into the confirmed cases area. So always going from suspect, which can be can have a disease or not, to the confirmed. Don't start with the confirmed. He treat the confirmed cases, and then he go back here, he change, they take his gloves, they clean it and disinfect it. He goes back. Now for the patient cannot enter the ETU from where the health workers enters. The patient, as I said, their zone is at risk because either they might have the diseases or they have the disease. So if you are a suspect case, you enter here. By here, they do a screening. They ask you questions to know if you are sick or not. If you meet the case definition of Ebola, they bring you in your room here, they take you samples, they examine. In the next 4 to 12 hours, you have your results. If you are a confirmed cases, they bring you here to the confirmed cases, and they start to treat you from here. And when you will heal, you will leave from here. But if you come directly and you are a confirmed case, you are not going to be screened here because you might infect the suspect cases. So you'll enter by ear directly, and then they start taking care of you. So always, for health workers, unidirectional flow from the low-risk area here in black to the suspect cases area, to the confirmed cases, and then you go back, you disinfect yourself, and then you come back again to the low-risk area. So this is the summary of the flow of patients and health workers in the Ebola treatment centers. Lastly, I'm going to go a little bit quick. IPC is not only in the treatment centers. You need to implement as well in other healthcare facilities. For example, if you are sick, you don't know if you have malaria, you don't know if you have typhoid fever, you would go to a nearest healthcare facility. And as IPC expert, we need to put in place some infection prevention control measures to make sure that everybody who arrives in any facility at risk, for example, in any facility, all the facilities, they need to have a system of screening everybody who is entering in the healthcare facilities to make sure that we separate people who are suspected and people who are not suspected, they go their way. And those who are suspected, you need to call the investigation team who will arrive to your facility and who will make in-depth investigation and decide to send the patient to the Ebola treatment centers. You need to make sure that you have adequate hand hygiene capacity. You have a system of sterilization of materials. You handle well the waste, etc., etc. But as well as IPC expert, there are a lot of high-risk patients in the household. If somebody is sick, the probability that the people in the same households to be sick is high as well because they were in contact. So we need to continue doing the follow-up of all the members of the households. And when somebody experience symptoms, you need to remove that person from the household and bring him to the treatment center. And also all the area where the patient visited, for example, you went to the church, you went to school, is a student, you need to know that the probability to have new cases will be in that search, in that school, in that market. And there are some infection prevention control measures that you need to implement. You need to clean, to disinfect, you need to screen people that he meets, and to do what we call contact tracing. You need to disinfect the household, the churches, and I think that's why you can see the team in Uganda, they are disinfected some households, and that's what we call the IPC. We have a case here, and then we look at a perimeter where we say, in this perimeter, the probability of the case of the person we seek, he might have in contact with people in that perimeter. And that perimeter is called the ring. And you have to implement IPC measures in the different facilities, the different households or community settings in that perimeters. Thank you so much. I think this is my last slide. Over to you.
Thank you very much, Dr. Kabego. Really valuable information. Tole, do you have some questions from our participants today for Dr. Kabego?
Yes, I do. So there are folks who had sent questions earlier. Allow me to begin with that. Shamim, a health reporter from Uganda, is asking, why is this Sudan variant so alarming? And also, there's a question, we've never had Ebola lockdowns before. Why now we have a lockdown? Allow me to ask another question, which is about the lockdown. Musa Polite is asking, he's so concerned, and he's saying the Ministry of Health in Uganda last week declared that all Ebola patients have been discharged, but people from Mubende and Kasanda are still under lockdown. Do you medics recommend such? That is the first round. I still have a few, which I will ask later. Back to you, Dr. Landry.
Yeah, thank you so much. This is, I think they are very good question. I will go straight to the point. Why Sudan variant is so alarming? Compared to what? To desired variants? I don't think so. So far, it looks like the Zaire variant has the higher mortality than the Sudan virus. For example, the mortality rates in the 10th outbreak, the biggest outbreak of Ebola in DRC, the mortality rate was around 67%. For Sudan virus is around, it's below 50%, if I'm not mistaken. It's Ebola virus is always a very dangerous virus. If you compare, for example, with COVID-19, the mortality rates of COVID-19 was very low compared to the Sudan virus. Even though the difference as well, the COVID-19 has a higher transmissibility than Sudan virus. So we need to consider each virus as an individual threat and how to implement the measures. So the viral hemorrhagic fever diseases will always be alarming, either this strain or the Zaire strain or the other strains. No Ebola lockdown before. Why now? As you saw in my first slide of the chain of transmission, one of the methods that you need to use is to isolate the reservoir so the virus cannot move out and meet other people. So the danger, the threat here was to, actually, I'm not in Uganda, but I'm going to explain why the lockdown. The threat here is to leave everybody circulating everywhere, going everywhere, going in DRC, in Rwanda, in Kenya, in other districts inside of Uganda. And the threat is we may have positive patients, confirmed cases, who will go to other districts and who will start another chain of transmission, and another district will be affected. You can see at the beginning, we had only one district affected, and then now we have 9 districts affected. But for example, if at this very beginning, we detect it earlier, the first case, we isolate the case, or we isolate as well, we put lockdown in the districts, maybe we could have controlled the outbreak in the beginning of it. Ebola patients have been discharged by Mubende and Kasanda still in lockdown. Okay, when do you decide that the Ebola outbreak is over? We decide that the Ebola outbreak is over 42 days after the last case has been discharged from the Ebola Treatment Center. Why 42? The incubation period of Ebola virus is 21 days. So we take twice the incubation period, and we decide that is the threshold. We have controlled the outbreak. So far, I think that's the outbreak is not controlled yet. So there are some epidemiologic elements that might trigger the Minister of Health to keep the lockdown in Mubende and Kasanda. And maybe nobody asked it. There is another way that Ebola can transmit to one person to another. And this is for people who have recovered from Ebola. So you take their samples, they are negative. You take their sample, they are negative. You discharge them. But the virus stays longer in reproductive cells, in the sperm, for example. So people who have healed, who have recovered from Ebola, can still transmit the disease to their partners when they are having sexual relations. That's why also when we discharge people, there is a program or a project that we put in place, which is follow-up of people who recovered. You need to see them regularly, to take them samples, to test until they are negative. They don't produce anymore the virus in their through their sperm, and it might be the origin of the 10th outbreak in North Kivu in DRC. It's probably somebody who came from far, from another province, from a previous outbreak. He had recovered. Maybe 2 months later, he traveled for duty to another province, and he infected the first person. And after, we had to spend 2 years fighting this new outbreak. Thank you. Over to you.
Thank you very much, Dr. Landry. Allow me to ask another set of questions before we move on, because we have quite a few. So there's a question about the vaccine. Why has it taken so long to produce the vaccine? And then also, Graciela is asking for an update on the situation of the clinical trials of the new vaccines against the Sudan strain. Also, we have a question. A journalist from Uganda is asking how Alomu Dilax from Vision Group is asking how best can media cover the Ebola outbreak without endangering their lives? Thank you.
Thank you so much. When it comes to the vaccine, I'm not a vaccine specialist, but a vaccine, it doesn't take long to be produced. This one, because we spent how many days, maybe 2 months in this outbreak, and now we have a vaccine that is ready for clinical trial. I cannot provide the updates. I think somebody from the country can better respond on the update of the clinical trial. But for the Zaire strain, there is vaccines that have been used. For this strain, we do not have a vaccine. There is one that will start the clinical trial. How best can the media cover all these Ebola issues? I think what we do, for example, in WHO, for example, me, I'm an infection prevention and control specialist. I'm not really expert in communication, and especially in communication with the general population, because the general population, it depends on many things. It depends on the culture, on the behavior, on the religion, on many things. I think we need information from social anthropologists. We need information from experts in communication, and these are the ones who can translate the evidence based intervention that we want to implement into right words to use in the community. I'm going to give an example. For example, in DRC, when we're doing self-identified burials, we faced many issues in the community. People were, you cannot touch the body, you cannot, they are in the body bags. But it was very difficult because at the end of the day, they were opening the body bag. So we could not understand why they are opening a body bag, and we are telling them, if you open the body bag, you are going to be infected. So the anthropologists, when they did some study, they asked questions, focus group, and they understood that the community, they want to see the body. So what we did, we changed the black body bag into a transparent body bag, and it was okay. They could see the body through that transparent body bag without opening it. So I think that the way the media or the communication team should make a link between IPC specialists and the community. Over to you.
Thank you, Wayne. Should we continue? I shoot questions. I still have more.
We'll come back. We'll get back to go over some more questions. Thanks, both of you. Now I would like to introduce you to Esther Nakazi. She's a freelance science and technology reporter based in Uganda, and she writes for various media outlets around the globe. She's also the
I think we've lost him.
Yeah.
I think we've lost him. Esther, you can go ahead.
Okay, thank you very much for the introductions. My name is Esther Nakazi. I'm a freelance science journalist and the founder of the Health Journalists Network in Uganda, which is a group of journalists that write about health really in the country. And we have sister organizations in Kenya, Zambia, Zimbabwe, and Malawi now. And I'm just going to take you through the story, what has happened, and my focus will be on the Ebola story, the experiences, all obstacles, and the advice, and I'll be very brief and quick. So when the story broke out, when we had the outbreak, definitely that was a big story to cover, because when an outbreak happens, we, the journalists, have to speak about it. So we broke the story, there's an outbreak, this is happening, and yeah. And then we progressed to what type of virus. You know, at that point in time, when the outbreak had happened, some people are just saying, oh, we have an Ebola outbreak. And then we had to clarify about what type of virus strain this is. And we understood that it's the Sudan strain and it didn't have a vaccine. And we tried to talk about the control efforts that were being done. We all the time put in a lot of effort in explaining what the government was doing, the health workers were doing, and we did highlight a lot of stuff about the health workers who are dying. So I remember that in the stats that were being given, and they are still being given by the Ministry of Health, they were showing us how many health workers were dying, because Ebola is really a disease of the community, but also health workers are at risk because of what you have heard from Dr. Kabego. So we explained what was done, the control efforts when the government decided to have a lockdown. We did that, and we put a spotlight really to health workers. And then we had the funding issue where the ministry was looking for funding, and then our donors said, no, we are not giving the ministry funding. And then there was a lot of misinformation that was happening, as Sylvia has explained, on social media, and all that was explained in our stories. So the story has now evolved. We moved away from that. We are now looking at clinical trial. What is happening? Where are the vaccines? When are they arriving? We keep going back and forth, and I actually expected some answers from the WHO, because here in Uganda, when you call the officials, they're like, speak to WHO. Then yeah, we need some answers as to what is happening around the vaccine trial. We know they have said that 95% of the trial is done. The protocol has been approved, the health workers have been trained, the community is ready for it. But I mean, the major component is the vaccines. And where are they? We don't know. So that's something that's a little bit, on our side, is a little bit confusing. The contacts are getting smaller and smaller, less and less. And we know that the vaccine trial, the trial is based on the contacts, or people who have been in touch with people who were sick. And we know that cases have gone down to 0. So that is another thing that we are also looking for information for, what is going on. If there are no more contacts, will it happen or it will not happen? Containment efforts, epicenter districts, Dr. Kabego has just explained, but you know, people are wondering, why is there a lockdown? And prior to this, we had fears that the whole country would be locked down, and thank God that didn't happen. But when it was, we had all those stories about school children being ferried from the epicenter to their homes when schools were closed. Schools were closed prior, and that was an important story for us, because, you know, during COVID-19, Uganda is the one country that had 2 years closed. Schools were closed for 2 years. Our children were seated here in our houses for 2 years. So there was a bit of concern when that happened, and everybody was like, what is going on? So this lockdown thing was also a very big story, and it's still a big story. And it affects not only the community there, but the businesses there. The traders are not making money, they are crying. So those explanations need to come through, and we need to give them to the public. And based on what Dr. Kabego has explained, we have a duty to explain to the community. And then the containment efforts, there's a lot of training now. The other day we had the Kampala KCC, Kampala City Council, trying to explain what is going to happen during the festive season to stop, to prevent really. And all these efforts are being done, and in the epicenter, you know, the lockdown is still on, and those preventive efforts are being said. And the funding, yeah, we still need to know where is the money coming from, because this is a big project. It's running in billions. Where is the money? Who is funding it, and where is it coming from? In my own experience, we have had, I think we've had a good experience with the WHO. They have been giving us updates, although we lack some information. The government has also been very responsive. The Twitter feed gives us updates every now and then about how many deaths, how many cases, what is going on, and that's a good area for us to look out for. The Twitter feed really helps and works, and we get the information from there, because you cannot write an Ebola story without giving people the stats. What is going on? How many contacts are there? How many deaths are happening? How many health workers? So that has been a good thing. Scientists are explaining some things, although in my experience, it has not been very good. I've tried to understand really why is the clinical trial not happening. I don't know how many scientists I've called this week, and everybody's like, ping pong, ask WHO. No, when I ask WHO, they are saying, we ask you, no, ask. So the information is not forthcoming. Why? Why are the vaccines not here? Why don't we have them in the country? Well, they've said, some have said the shipments are still going on, but yeah, they already said that so many weeks ago. So the urgency of the story also needs to be explained. We need this information, and we need it now, and it would help us really write the story, because it would make everybody understand what is going on. If the protocol was approved, if the funding is available, why are the vaccines not coming? Just we need to know that. The community is also on its toes, especially where the epicenter is, because as you can imagine, it's getting to Christmas and the lockdown is on and all that information, but they are willing to tell what is going on in their community, and pretty much abiding by the rules that have been set by the government. There's been a case though, a story of one of the districts in Masaka where information was different. The community seems to say, no, this person didn't die of Ebola because she was pregnant and had a miscarriage, but the health workers have alleviated those fears and said, no, we tested and we know that she died of Ebola. So that is happening. So my advice is to keep the story going, keep the story alive. And because for a long time, although we are reporting a lot of Ebola here, the international community wasn't really reporting about it. And you know how that affects us. So right now, thank God it peaked and it's going. A threat to other countries, we need to show the potential. I mean, we had Africa CDC and the WHO come here and train people, health workers, and everybody who is concerned, so that the disease doesn't spill. And that needs to be communicated. People need to know how Ebola is spread. Thank God Dr. Kabego has also explained that. And we need to collaborate as journalists. I mean, I've had so many people call me from everywhere, like, oh, tell us what is on the ground. And we do offer that information to other journalists, because if the outbreak was in DRC and I wanted to write about it, I usually also call journalists in DRC and say, hey, this is happening. Why don't you give me some information? What is on the ground? I mean, I need background information before I speak or do interviews with a health official, because the person who is on the ground knows better. And the collaboration really helps. There's been a lot of not a lot, but Sylvie has explained it. There's been misinformation, disinformation on what is happening. One of the things that really happened was the exhuming of bodies. When the MP went to Parliament and said, yeah, this is happening because there's been exhuming of bodies. And then we had this video running around in Uganda, and the guys from Kasanda were saying, no, we didn't do this, and we didn't exhume the bodies, and so who is right, who is telling us the correct information? That's something that journalists have to guard about, because I had a call from the US and somebody was like, oh, we've heard that people are pulling out bodies from the ground after they've been buried. Is it true? Is it happening? So there was conflicting information. What I saw on the Twitter, on the WhatsApp page with the locals alleging, no, it didn't happen, and then different from what the legislator said were two different things. But yeah, the government had a position, and they did tell us that it happened and they were exhuming bodies. So there was a more misinformation, or information circulating around, of course, about funding and how this is being prolonged, like Sylvie said and explained. And it goes round and round, and people hear that and they keep thinking, well, maybe it's really not existing. And it's our duty as journalists to say, yeah, the disease is here and it's killing people, and it's a dangerous disease, and it's, a bad disease. And we did have training, by the way, by the government telling us really what is happening and who, why, what strain, how should we avoid it, and all that. We need to create scientists to create trust with scientists, because we saw a lot of that with the COVID-19 vaccine, rather COVID-19 pandemic. And so this time when we are writing our stories, we really need to listen to the scientists. They tell us what they know, and we need to put that, because I mean, if there's this disinformation that people want to make money off of this, then in the mindsets of people, they'll be careless and say maybe it doesn't exist, but it does exist. It has killed people. It has killed people we know. So the scientists need to be quoted. They need to give us information, and we need to pass it on. We need to explain in simple terms what this is. It is caused by ABCD. It's a zoonotic disease. People need to stop, interacting with certain animals so that they don't pass on the disease. Preventive measures are here. This is what you need to do. Wash your hands, do that. If the lockdown has been put in place in the epicenter in your area, don't escape and run to Kampala or to wherever, and stop issues of thinking it's witchcraft. Don't take herbals because it's not going to help. There are all these measures that are and there is help, there are treatment centers that are available. So all this information needs to be given by us, the journalists, to the public and the community, so that we also play a part in the fight against the disease, which is very dangerous and kills a lot of people. But we need to explain in simple terms. Fact-checking information, of course, there is a lot of information that was running around. And, when the minister came out and said, oh, it's also spread by semen, of course, studies had been done by Dr. Kabego has said in West Africa, but then social media took it to another level of saying, oh, okay, they can have sex, oh, this, that, oh, it's an STD, So you need to clarify, read the studies, understand what's going on, put it in there if there's information you're hearing, and try to inform people and educate them that, yeah, in West Africa it happened, a study was done, and this is what it showed, and it was the ESAR virus that was in there, and this is for real. So that's our duty as journalists. Where do we get information from? We get information from the government. Like I said, I've been calling, hey, when is the vaccine? When are the vaccines coming? Why are they not here? Why? How many contact people do we have? And I'm on top of the Twitter page all the time, trying to get the stats, which are important, and we need to put them in the story. WHO gives us information. We have scientists who are giving that. On our own website, the Health Journalists Network website, we also put information from different, writers that is coming out, and we put it in there. And then we need to read. It's also very disheartening when our health officials listen to us and we are asking questions that have already been talked about. So it is our duty as journalists to read, listen to each other, know what is going on, and keep on top of the game so that it makes sense to everybody. So thank you very much, and over to you.
Thank you
Thanks,
very much, Esther.
Oh, I'm back totally.
Oh, fantastic.
And I'm very sorry for my technical issue that I disappeared for a while.
So we still have a lot of questions. I'll try to squeeze in because we are almost on top of the hour. We have Henry Owino, who asks, how long is Ebola jam active on a surface? Then Ben Musanje asks, how long does it take for an Ebola victim to get full recovery? And then we have, what are the chances of recovery if a person contracts both Ebola and COVID-19? And Flavian Asaka, a journalist from Uganda, asks about the origins. The patient 0, was it zoonotic jump or human-to-human transmission? And there is a question here also. Alex is asking what is the name of the vaccine on trial for Ebola and when will the trial end? And finally, Ben is asking if an expectant female Ebola victim gives birth during treatment or isolation, what are the chances of infecting the baby? Asking about mother to child transmission. Thank you. A flurry of questions to Dr. Kabego.
Thank you so much. For the first question, how long the Ebola microorganisms can still active on the surface? There are some in vitro studies that they have made. It depends on the environment. If it's a wet surface, Ebola doesn't stay long in the environment. All envelope viruses are very easy to kill and they die very easily. And Ebola is an enveloped virus. So in vitro studies, it might goes up to 3 days at a dry surface. But if it's a wet surface, for example, it's inside vomits, a high quantity of vomit, it can take more days up to 10 days or 14 days.
Excuse me, Dr. Kabego, can you adjust your sound? We're not hearing you too well. Perhaps move your microphone. Okay. There we go. Thank you.
Okay, thank you. Thank you so much. So in wet surfaces, dry surfaces, 3 days, wet surfaces with vomits, diarrhea, 10 days to 14 days. How long the Ebola full recovery? It depends from one patient to another, the immunity of one patient to another, but it can take up to 2 weeks. A chance to recover when you have Ebola plus COVID. It's a tricky question, but always when you have one infection plus another infection, the severity is high than having just one infection. If you have Ebola itself, the severity or the risk to die is much less than if you add another type of infection. The Ebola, the patient 0, I don't know if it comes from an animal or it comes from, but usually, I don't know, but maybe the investigations that are being conducted, they can give us more information on the patient 0. I'm not aware of that one. I don't know what will be the name of the vaccine And if a female gives birth, the probability of the infant to the baby to get infected is high. So the baby needs to be tested. If the baby is negative, the baby should be removed from the mother and being followed up for 21 days to see if the baby develop this disease or not. And the breastfeeding need to stop and use alternative for breastfeeding. Thank you. Over to you.
Thank you. If you have one more. There's an interesting question here from Julius from Zambia. He's asking about the reservoir. He says with HIV, it resides in the CD4 cells. And where does the Ebola virus hide or reside to multiply? Julius Kachiza from Zambia is asking.
Yeah, Ebola multiply in many type of cells, and that's why it's a little bit more dangerous.
Thank you. I have a question for Esther. I'm getting the impression from the social media talk that Sylvia told us about that, and perhaps some statements coming from the top official of Uganda, that there's a feeling that the outbreak is coming to an end. But Dr. Kabego has told us we're not near the 42-day mark where you could say that that an outbreak is over. Esther, what do you think journalists can do to sort of counter this, I think, misconception that we're all in the clear now?
I think, thank you, Wayne. I think because when the ministry announces typically that these are the last people we are discharging from the Ebola units, and then also these are the contacts, and we have kept them for 21 days. They are no more. So in the community, in our minds, everybody is thinking, well, this is over, and yeah, I mean, it just reflects like that. But I think as journalists, we need to make people understand and explain what Dr. Kabego has said, that after 42 days, that is when they will know that this is completely over and it's done. And even if it is done, we also still have these survivors who can pass it on. So don't, these are the issues that you need to take care of. And if they are saying the lockdown is happening in Kasanda, please agree on these terms and stay in your place and don't move to other districts, because you can spread the disease. So it is our duty as journalists to do that. But on the on the surface of it, as you can see, people will mistakenly think it's over, it's gone. It's everything is being celebrated.
So as journalists, we have to reinforce the actual facts of the situation and make sure that people still understand that there's a ways to go here.
Exactly, that there's still a risk and they should adhere to the preventive measures that are being announced by the government, even if there is no cases that are being announced by the ministry and the contacts are going home. So the lockdown questions have been going on and on forever. And, what he has just explained is something that we need to explain to the public and the community to understand, yeah, the lockdown needs to happen until they confirm that the risk is over. Yeah.
Thank you so much. Unfortunately, we are at time now. I'd like to thank all of our speakers today for a really interesting conversation. I'd like to let you know now that we will send the recording of this dialogue to everyone who joined us today. We'll send audio excerpts of today's presenters to our full journalist network via WhatsApp as well. And as always, we'd like to hear from you. If you find this dialogue useful, if you use it in your journalism work, we'd love to hear about that. It gives us an idea of how we're doing. And also, you know, if there are topics you'd like us to tackle in future dialogues, please let us know. Many thanks to Dr. Landry Kabego, Esther Nakazi, and Sylvia Samariva for joining us today. And until next time, for the RCCE Media Working Group, I'm Wayne Sharp saying thanks for joining us and stay safe.
Thank you.
Thanks,
Stay
Wayne.
safe.
Bye, everyone.
Bye. Thank you.